Macular hole surgery is one of the most commonly performed surgeries in vitreoretinal specialty. Ever since the introduction of macular hole surgery, it remains a highly successful procedure with high anatomical success rate of more than 90%. However, situations like chronic hole, large hole, myopic hole, and traumatic macular hole, the closure rates are low. Various surgical strategies have been introduced as an adjuvant procedure to attempt the closure of refractory macular hole, like pars plana vitrectomy with ILM peeling, pars plana vitrectomy with inverted ILM flap technique, pars plana vitrectomy with ILM peeling with arcuate retinotomy, pars plana vitrectomy with ILM peeling with relaxing retinectomy plus retinal autograft, pars plana vitrectomy with ILM peeling with macular buccal. The challenges one can face in myopic macular hole are due to high axial length, rigid and taut internal limiting membrane along with epiretinal membrane, relatively reduced elasticity of retina compared to sclera, the stretching of inner retina causing myopia foveal schisis, and poor contrast due to the underlying RPE atrophy, and the need of special instruments with high axial length. We present one such case of 55-year-old female with high myopia with posterior staphyloma who had posterior pole retinal detachment. This is the pre-op OCT showing posterior staphyloma with neurosensory retinal detachment, for which she underwent pars plana vitrectomy with silicone oil injection. Post-operatively, she was found to have full thickness macular hole with subretinal fluid. This is the post-operative OCT showing full thickness macular hole with residual subretinal fluid with posterior staphyloma. A repeat pars plana vitrectomy along with relaxing retinectomy with neurosensory retinal autograft was advised. Silicone oil removal was done. Brilliant brow dye assisted ILM peeling was attempted. Inferior relaxing retinectomy was done. From the retinectomy edge, a retinal autograft was obtained using horizontal scissors, and it was fashioned according to the size of the macular hole, and it was then mobilized to the macular hole under perfluorocarbon liquid without lifting the graft to prevent any accidental flippage of the graft, and it was placed over the macular hole. Barrage laser was done to the retinectomy edges. This is a post-operative fundus showing attached retina with laser marks. The post-operative OCT showed closed macular hole with attached retina. A 36-year-old male who had RD surgery elsewhere presented with us the reduced vision post-operatively. On examination, he had full thickness macular hole with regumbraneous retinal detachment with PVR membranes. He was advised for silicone oil removal with relaxing retinectomy with inverted ILM flap along with re-silicone oil injection was advised. 3 25-gauge sclerotomies were made, and the superior ports were made more posterior, closer to the horizontal axis for better accessibility. PVR membranes were removed. PFCL was injected. ILM was stained with BBG dye. An ILM peeling was done. (360° relaxing retinectomy was made and hemostasis was obtained. And silicone oil was injected. There have been multiple publications of myopic macular hole which was managed similarly. To conclude, myopic macular hole is a surgically challenging one. Various surgical options are available and neurosensory retinal autograft can also considered as a treatment option for the closure of recalcitrant myopic macular hole. Both ILM and the retinal graft plugs the hole and acts as a scaffold for glial cell proliferation to accelerate the closure of hole. Thank you.